Thank you very much, Chris, and good morning. It's a pleasure to be here at the King's Fund again, and a pleasure to be here talking about telehealth and telecare. Now, I was thinking how I might start today's remarks, and I think it's worth just sort of saying that hopefully most of us who are here today are reasonably fit, reasonably well, because you've all managed to make it here. Of course, those who are watching on the live streaming, I don't know, but those of you who are here, by definition, are fairly independent when it comes to your ability to make choices about how you lead your life. But for many people in England, the story is far more complex and complicated than that, because for people with long-term health conditions, life can be an endless succession of doctor's appointments, of nurses' visits, of time being spent in hospital. And for them, being independent is doing what they want to, going where they want to, and when they please, and it can often be for them a luxury they don't always enjoy. And that, I think, was the case not just for Harris Patel, who is here and will speak for himself later on, but also for Joe Barr, who by the age of 60, hardly old, and dare I say a little younger than Chris here as well, but I hope you don't mind me saying that, I should have checked. I'm 50 this year, so I'm going to give that up before anyone points it out. He developed a number of long-term health conditions, and they included COPD, they included diabetes, they included kidney disease, and also obesity. And his whole life was built around his conditions, not around his personal goals, his wishes, his feelings, his ambitions. And he probably felt like he spent more time in the NHS waiting rooms than he did with his wife or with his two dogs. Now, of course, Joe's story is far from unique. There are around 15 million people in England who have a long-term condition of one sort or another. And as our population ages, that figure is only going to go up. But Joe's story didn't stop when he became ill, because he was lucky. He lives in Cornwall. And of course, Cornwall is part of the pilot project that is testing the benefits of telehealth technology, a project that, in Joe's own words, provides a brilliant service that means, and I quote, "I can take responsibility for my illness." Now, you wouldn't be here, I think, if you didn't already know something about the Whole Systems Demonstrator. There's been a fair amount of reporting on it now around the place. So I'm not going to go into every last detail of the Whole System Demonstrator. Indeed, there are others who are far more expert who will be on the panel who will be only too pleased to take your questions later on. But I do want to shout, really from the rooftops, what it's done. What it's done for people like Joe, for Harris, for many, many thousands of others across Cornwall, across Kent, and in Newham in London. Quite simply, it's given Joe back his life, and by understanding his own particular needs and then integrating specific technologies into his care plan, he now has his independence and, to a significant degree, control over his health. Now, he knows that his condition is being monitored, and that if anything is heading in the wrong direction, then it can be dealt with immediately. And he can have friends and family round when he wants. He can go where he wants. He can do what he wants. But that's because he no longer has to stay in all day, waiting for the doctor, waiting for the nurse to call. Because he no longer has to spend hours also in hospital waiting rooms. And because his vital signs are being monitored constantly, anything that could become serious is picked up before it has a chance to become so. So I think there's really a very important lesson from what we have gathered from the work of the Whole Systems Demonstrator. Telehealth worked for Joe because it first understood his needs and then looked at how the technology could be applied to supporting and meeting those needs. And it started with the patient as a person, not just dealing with them as a bundle of health long-term conditions. It didn't start with the technology. But all too often, I think this is the reverse of what happens in practice. Some, in some primary care trusts, see a nifty piece of kit, think it's the latest innovation, buy loads of them in, and then wonder why it ends up gathering dust in cupboards. And I've heard stories of hospital trusts doing just the same. Good telehealth, or indeed good telecare, is not about the technology. It is absolutely about the person. It's about empowering people to live their lives as independently as they can. The technology is an enabler. It plays an important role in that regard, but it will only ever fulfill its potential if it is integrated into a properly designed patient care plan, and if it supports a particular individual's needs. In that sense, this is fundamentally about how we make our healthcare system a genuinely personalised and personal healthcare system. In that sense also, it's the same for the whole of the health and social care system. Because up until now, each part has, to a very large degree, organised itself around its own needs. Hospitals around what hospitals need, GPs, dare I say, around what their practices need, and social care providers around what they need. And we've ended up, in that respect, with a very disjointed, often confusing, definitely difficult to navigate, fragmented system. And what we need, I think, more than anything else in the years ahead is to take the approach that Joe's team took with him. They started with Joe's needs and built the systems around him and fitted them with his life. And if I get sick and need help, I don't think it really matters who's going to provide that service. It matters whether they're going to deliver the outcomes that are right for me, whether it's the NHS, whether it's the local authority or someone else. I want to make sure that what's provided wraps around my life is a seamless care service. But it also matters very much if my healthcare is not integrated with my social care, if my GP doesn't work with my care provider, if the time in the hospital and the way it treats me doesn't involve me directly in shared decision making, or that my GP or my social care provider are not directly involved in drawing up a discharge plan when I leave hospital. So fully integrating care means starting with the person in the middle and building outwards. And it means making care more effective. It means managing conditions better and preventing small problems from developing into major incidents. So it does, as I say, mean shared decision making. It does mean a personalised approach. And if this is the way that we approach telehealth and telecare, then I think the potential benefits for people using it, for healthcare professionals and for the NHS as a whole, indeed for our society as a whole, are truly enormous. And that just leads me on to some of the headlines that came out of the Whole Systems Demonstrator. And I think some of them are truly staggering in terms of what they found. A 20% fall in hospital admissions, 15% fewer visits to A&E departments, a 14% fewer elective admissions, 14% fewer bed days in hospitals, and an 8% reduction in tariff costs. And whilst those may have been some of the things we hoped and expected to come from the Whole System Demonstrator, perhaps one of the most staggering, indeed stark, outcomes from the pilots, and given this is a randomised controlled trial, I think all the more impressive for that, is that it has also led to a 45% difference in mortality rates between those benefiting from telehealth and those that were not but were in the pilot. And I think that was quite an unexpected and I think truly extraordinary finding from the work. And all of this has a significant cost implication for the NHS, in the right direction, I should hasten to add. Already we know that 7 out of 10 inpatient beds are occupied by people with long-term health conditions. About 70 pence in every NHS pound is spent on looking after them. So by keeping people out of hospital, by reducing the time that they're there when they have to go in, and by being far more targeted and efficient with the use of NHS resources, we estimate that the widespread adoption of telehealth and telecare could save the NHS up to £1.2 billion over 5 years. But this is not just the case of me saying it. It certainly is not going to be the case of ministerial edicts driving this transformation that we need to see. Because what this government, I think, has learnt more perhaps than any before it is that it does need to understand the limits of ministerial power. And once a government might have set a target for this and said, oh, well, we're going to have 50% adoption of telehealth for long-term conditions by 2015. And we may well have mobilised the system to hit that target. But it's very likely they will miss the point and not actually have transformed the services and resulted in large amounts of kit being acquired but not being used to get the optimal benefit for patients and certainly not delivering the integrated and personalised care that I think is so important. And we need local providers and local commissioners to look at the needs of their communities and make decisions based on the clinical and social needs of their patients. If the technology can help, then it needs to, and we need to remove all the barriers that get in the way of that happening. But the way to do that isn't to impose it from above, but by making it easier to do and to leave it to the best judgment of people on the ground to see it through into practical delivery. And at the moment, I think there are several issues, several barriers, if you like, that are in the way. Initially, there was a lack of evidence. People said, well, we don't really know this will work. Prove it to us that it can actually make the difference. And I think the Whole Systems Demonstrator has comprehensively taken care of that. The evidence, I think, is now compelling, and as we see more of it published in peer-reviewed journals over the coming weeks and months, I think it will give people even more confidence that investment decisions you need to be making now are the right decisions. But people need to know about it and to understand what it can do, to know how best to utilise it. And I think there are some technical issues to get over, such as a general lack of interoperability and confusion over incentives in the system. And of course, this stuff doesn't come for free. Whatever the long-term savings, there are, of course, substantial upfront costs. And that's why the Department of Health, my team in the department and myself have been working with industry and with the medical professions to start systematically removing those barriers, to raise awareness of what is available and how to make the most of it, to move towards standards of interoperability, and to look at innovative ways that providers and commissioners can pay for telehealth and telecare, such as through ongoing contracts. Now, few people buy iPhones or Blackberries or any other bit of technology that we use to communicate with one another with an upfront cash payment. Few of us could afford an upfront cash payment for the latest iPhones at any one time, and we pay for it instead through monthly contracts. So why couldn't a community nursing provider pay for a remote blood pressure monitor in a similar way? We're already seeing exactly this in places like Gloucestershire, where the NHS is working with Tunstall, as we've already heard, one of the largest telehealth and telecare companies, and Tunstall cover the upfront costs, such as clinical engagement, pathway redesign and training. They then supply NHS Gloucestershire on a per patient per month basis. Any cost savings that the Commissioner makes through this, through likely reductions in hospital admissions, can then be reinvested back into frontline NHS services. And NHS Gloucestershire avoids the need for large upfront costs. It enables the supplier to build relationships with patients and customers that it otherwise would not have had, and it enables patients that priceless gift of getting their life back and being in control of their life. So I think it's a win for the NHS, it's a win for an industry that this country should be wanting to see grow, and it's a win for the patients as well. And with the right incentives and the right business model, the benefits for everyone, I think, really are huge. And in time, the cost of the equipment will start to fall. Costs in the UK are already significantly higher than they are in the US, and it's no wonder, because in the current situation we have only 6,000 users compared to 10 times that number in the Veterans Association in the United States of America. And that's why we're looking at promoting our campaign for 3 million lives, why we want to grow this potential base of patients using and benefiting from this technology rapidly. Just think of what a market of that size can do in terms of innovation, in terms of economies of scale. And we need to change the way we do things, working in partnership with industry and with the NHS and with colleagues in social care and the voluntary sector, and I think most important of all, with patients and carers, so that we get this right in delivery terms from the bottom up. And to show just how committed the government is to all of this, we've already signed a concordat with industry, with the trade associations, signalling our clear commitment to work together to spread the benefits at scale and pace over the coming years. Now, there are issues that come from the potential market of that size, principally problems of broadband capacity. That's one of the things that's not directly in the gift of the NHS or, for that matter, the Department of Health. But it's true that many of those who stand to benefit from telehealth and telecare will live in rural areas. I certainly saw that whilst I was down in Cornwall earlier this year. And areas that are not particularly well served in terms of broadband access. And that's why, where the numbers don't stack up for businesses to invest in broadband infrastructure by themselves, we are willing to step in and tip the balance. And that's why we've earmarked over £500 million in the spending review to support broadband rollout in rural areas, and whilst we're running 4 pilot schemes in places like Cumbria, North Yorkshire, to see how we can most effectively bring the benefits of broadband to this country. And there's also issues around people within the NHS and social care not necessarily having all of the skills and understanding of the potential benefits of the technology. And that's why we've asked the NHS Institute to develop a support programme to make sure that patients and staff are properly supported and properly engaged with to help make the most of these technologies locally. Now, this would include developing a series of how-to guides and advocacy campaigns to build patient support to win over perhaps some who are questioning still the merits and value of taking this step. Making sure that everyone realises this is about improving outcomes, improving the lives of people like Joe and Harris, and not about wasting money on expensive kit. So as Joe said, in the beginning, my consultant would not look at the reports and pass them back to them, the data he was getting. And now when he asks me where my last 6 months readings are. So winning this argument locally will be the key to unblocking the benefits and unlocking those opportunities that the Whole System Demonstrator actually makes possible. Now, if local clinicians in the NHS, in voluntary and independent sector providers are convinced that this is money worth spending, and if local commissioners are convinced that it's the approach worth supporting, then the pursuit of better outcomes for patients and greater value for stretched budgets will drive progress far faster and far more effectively than a centrally directed and imposed programme. And Cornwall, for example, is so convinced of its value that they want to build on the benefits to 30,000 people over the next 5 years. And I gather Newham has also taken some decisions just very recently to move forward on the benefits of what they've learnt from the Whole System Demonstrator. And this is what has happened in the pilot areas, and it's increasingly happening beyond them too. For example, in Croydon, there are 3 GP practices who are using telehealth technology to monitor patients remotely. And when they feel unwell, they can talk to their nurse or their doctor on the phone with all the relevant clinical information readily to hand. And this saves obviously valuable time. It also allows something to be spotted early. It avoids wasting everyone's time if there isn't. And it's far more convenient. Convenient for the patient, convenient for the clinicians as well. And the results already show that the costs of the programme have been covered from the savings that have been realised from the programme itself. So our modernisation of the NHS and of social care is all about enabling people to take the initiative, putting people in control of their own care and treatment, putting local doctors and nurses and other health professionals in charge of how their money is spent, and making sure that whatever we do, it's focused on improving those outcomes for people. I think the proper use of telecare and telehealth has the potential to have a triple whammy, to hit all 3 objectives in one, helping to give people like Joe their lives back, putting healthcare professionals in charge of the technology rather than the other way round, improving the quality of people's lives, keeping them out of hospital and keeping them far more healthy instead. And all of this will play an absolutely crucial part in the information strategy that the government will be publishing for health and social care in the not too distant future. The way in which, for example, patients' records can be accessed, added to and shared electronically will be one of the key benefits, I think, of driving all of this forward. And giving people control of their own information, building that information around the individual, gives, I think, us the opportunity to reduce the numbers of duplications that take place in the system today. So just in conclusion, the technology really isn't where this starts. It starts with people. Technology, no matter how amazing it is just a tool. And I think the new approach is not about the technology, it's really about a revolution of another kind. It's a revolution in integration, it's a revolution in personalisation of healthcare that really does have a direct impact on the quality of life of 3 million people in this country. I hope that you, if not inspired by what I've said today, are inspired by the evidence and act on the evidence, because if you do, you'll be making a real transformation in the lives of thousands of people in this country, which is what I think we're all here to try and achieve. Thank you very much.
Paul, thank you very much. We'll hear very shortly from Harris about his experience and the benefits, but let's just take a few minutes to come back on what Paul has said. I'm going to start. We've got a couple of microphones and we've got about 10 minutes to engage with the Minister before he has to head off. Question in my mind is the NHS hasn't got a great track record in terms of the take-up of innovations. So what's going to be different this time around?
Start with a nice simple one first, very good. Well, I think the difference is, first and foremost, that we've learned that top-down, centrally driven programs are absolutely not the way to win hearts and minds. And when it comes to service transformation, what we are trying to do, and I know some people think, oh, isn't that what you're doing with your reforms? That we're actually trying to make sure that the power is shifted in the system to local decision makers. And once you've devolved power in the system, to make sure that the incentives through tariff design and through a real focus on measuring outcomes are the things that drive changes in behaviour at a local level. So what we are going to do is make sure people are equipped with the information, we're going to make sure they're equipped with the tools to do this, and we're going to equip patients to be the advocates for this change themselves. Because I think that's where, through shared decision making, we can really get a drive, really get the leverage to get the transformation we need to see.
Okay, thank you. So please, if you want to come in and ask a question or just make a contribution, put your hand up. We've got a couple of microphones. Ben, there's a gentleman there, and followed by two here in the middle. Is there anybody on that side of the room, just to be equitable, who wants to come in?
Thank you. Simon Rudland. I'm a GP in Suffolk. There were only 3 GPs who owned up to being present yesterday in the audience. I'm not sure how many are here today. In terms of commissioning, things are pretty hectic at the coalface. I just wonder what the Minister's plans are for sharing what we've heard about today with coalface GPs, with commissioners who are in a position to actually make changes, so that they know about these innovations and they have an opportunity to look to use them if they choose to.
So if we can just put the challenge back to you, I mean, you're out there as a GP, as you've said. What's the best way of communicating the message to you and people like you?
Well, I think we need a proper debate in the medical journals. I think we need to actually bring it close to home. He perhaps needs to get out and tell us about it. He needs to share some of this with his local MPs, who can also disseminate that information.
Yeah, okay. Does that sound
that's a good challenge. It's absolutely that sort of cascading is exactly what we need to do. In the very nicest of ways, and hopefully without giving any offence, I hope the BMJ will get on with publishing a number of the peer reviews that are sitting with them at the moment. That probably has stopped that happening, but really very important. I mean, we want to get the information out there, and I know there's a great deal of appetite to see the evaluations. So that will be a helpful way, as you say, getting that debate going. And we need a lively debate, absolutely. But what we don't need is, if you like, a further discussion of whether or not the evidence shows this works. I think we've done a randomised controlled trial. We know now on the basis of that this really can shift patients into settings that are much better for them and give them what they want, which is control over their health condition and their life. So absolutely, and if that was an invitation to Suffolk at some time to engage with some of your colleagues, I'll gladly take up the invitation.
Please.
Thank you. Steve Hards, editor of the Telecare Aware website. The Minister's support for the 3 Million Lives project doesn't sit very comfortably with his announcement in January that there was going to be no support for telehealth for prisoners, does it?
I don't know that it doesn't sit well with that. I mean, we've had a number of points of challenge from some of my MP colleagues about whether we would start to apply telehealth in a prison setting. And of course, one of the things the NHS Commissioning Board will have responsibility for in the new arrangements will be commissioning of prison health services. They will need to make judgments as to whether or not the rollout of telehealth should apply there as well. And the point I've been trying to make, obviously not well enough, is that ministerial edict saying you shall do something is often the best way to make sure it doesn't happen. And we want to make sure this happens on the basis of the evidence, and where the evidence shows managing long-term conditions in a prison setting makes a difference, then of course it should be used.
Please.
My name is Lawrence Touw from the Netherlands. Nice story about Gloucester. The big question is, from our point of view, how do you really save the money and not get creative hospitals making snoring services or what kind of services? So the cost you gain here is substituted by all kind of new creative services.
No, absolutely. I mean, that is a key part of it, and it's why getting the system incentives aligned properly and making sure that the design of the tariffs in the system for charging for these things are designed in the way that actually results in shifts in investment into the right places. So, for example, at the moment we're working on a year of care tariff for long-term health conditions. I think that will be very instrumental in supporting Commissioner decision-making around investment in this technology.
Please, Paul.
Minister, my name is Paul Rice. I work in the NHS in Yorkshire and Humber. I think we all see that there's a real transformation agenda here for the professionals, but you also picked up on patients and citizens, and I wondered whether we can revisit the fully engaged patient scenario and see whether in the NHS constitution people's responsibilities that telecare and telehealth enable are part of the bargain going forward as much as the transformation of the response in terms of services.
So again, Paul, what would you suggest the department ministers should be doing to promote that idea?
I think a lot of this will be about people having an opportunity to understand that the information enables them to manage their own choices and preferences. Their preferences around diet, their preferences around exercise, their preferences around smoking reduction or cessation. And I think we need to see that as a companion piece to the activities which will happen with 3 million lives about challenging the professionals and the new service models.
So ideas of patient-doctor contracts. Yeah.
I think the Constitution needs to revisit the question about responsibilities. I think it's a bargain for all of us in terms of the NHS, and I think patients. I think we would pull patients through more if that issue about responsibilities was reformed and reshaped.
Okay, I'm going to bring you 2 more questions and give Paul the last word. So the gentleman at the back, and there's one, Fiona, just behind you on the right-hand side.
Okay. Yeah. My name's Harry Longman. I run a thing called Patient Access. Interested that you're saying no top-down change. Fantastic, support that. We have evidence of 20% lower A&E usage linked with a very simple change. So you're not going to do it top-down, but how would you support this innovation in terms of, say, research on the basis of your philosophy of no top-down change?
Okay, and the gentleman over there.
Good morning. My name's Atul Kumar. I'm one of the other 3 GPs that was here yesterday. I might tie together 2 or 3, so I'll make my suggestion first and then ask my question. 2 or 3 of the themes. I think when considering the barriers to telehealth adoption, I try and think, well, what's going to be like once this is being done everywhere by everyone? So one of the things it'll be like is there'll be new tariff models that you've discussed. There'll be better integration of research. Patients will be pulled into their own self-care a bit more. One of the other things that I think will be happening is professionals will be better educated. I was wondering what the Minister's plans are, or whether there's any plans at the department to support and to encourage professional education.
Right, okay. Thank you very much for all of those. Just picking up Harry's first and the points about research. I mean, the point, I think, first and foremost is that we have already now a very rich research resource from the Whole System Demonstrator. There's a huge amount to mine out of that over the coming weeks, months and years, and we just need to get on with the peer review processes concluding and publication and the sort of academic and professional debate that will flow out of that. And we certainly want to support that going forward. And certainly when we launched the 3 Million Lives campaign in the House of Commons a few weeks ago, alongside that we had support, for example, from the Health Service Journal, who've written a whole document to sort of spell out a lot of the benefits about the research and so on. So it's about dissemination of research evidence as much as it is about building the research base even further. Having said that, I mean, I think one of the huge opportunities we have coming out of the reform agenda is the greater emphasis that's being placed on life sciences and research going forward, and the opportunities we have to really exploit that as a country for the benefit of patients. Atul's questions about training, absolutely, and that has to be, again, a collaboration. It has to be a collaboration with Royal Colleges, it has to be a collaboration, dare I say, with the BMA, it has to be a collaboration with patient interests and patient groups as well. And some of that is part of what we're working through. I mean, the first part of our engagement has been quite focused on getting the business model right with the industry. The next stage, if you like, of this process of cascading this has to be about getting those relationships right with professional and patient interests so that they are aligned with delivering this as well. And that's what we're working on now. And Stephen will elaborate in his points later on. And then I think just picking up on Paul's point, I mean, I think this point about the NHS Constitution is actually a very interesting one. The NHS Constitution has to have a sense of permanence about it to give reassurance that the underlying values that underpin the NHS are not at risk. But I do think it needs to also reflect the fact that it's still quite framed as a document addressing acute care and episodic care, rather than a document that's addressing the true experience of most people in healthcare, which is long-term enduring health problems, long-term enduring mental health problems. And therefore we do need, I think, as we look to refresh it, but maintain those essential values to address that. And therefore I think there are some things about integration, there are some things about individualised care planning, there are some things about navigation in the system which I think are essential to getting that right, and that's where the personalisation agenda in healthcare needs to learn from the personalisation agenda in social care in the future.
Paul, thank you very much indeed.
Thank you.